So the task that you gave me was about 10 things, but to be honest, it's almost impossible to talk about only 10. So probably you will face with someone more. So let's start from the classic slides that IRAD has to show. Disclosure, biomedical company that's supporting, have been supporting for this time, the registry, familiar foundations, and also University of Michigan faculty group practice. These are the support, the financial supporters of the registry. This is already old because I wrote only 54 active sites, but I realize right now that we are 60, so probably this afternoon will be 62. Exactly. So, but Elise is here in the room, so we don't know if we can accept them today. So we'll see. 3 founding fathers, Kim Eagle, Eric Selbacher, and Christoph Nienaber joined and have this marvelous idea in 1996. And they designed this initial general data form, an amount of variables, sometimes easy to fill, sometimes less, because very peculiar points were discussed. And then with Himanshu Patel, we had the privilege to increase the interventional data form in 2010 with additional more than 200 variables, like just to make everything easier and shorter. We were here when Elise sent to us this slide a couple of weeks ago, almost 15,000 patients, as regularly seen in the history of this disease. 2/3 are type A and 1/3 are type Bs. And these are the survival patients overall and those who had the opportunity to be followed. And that's another important point because IRAD is observational registry, so the follow-up is not so simple as in trial, and cannot be so precise in trial as well, but we are very satisfied about this topic too. Also, the IVC cohort enrolled up to now more than 5,000 patients, and we are ending up with some interesting points that are important to fix the surgical endovascular points that have been rising up over this decade. And these are where the results, or at least the number of patients who had the surgical endovascular or hybrid approach for this specific part of the registry. When we celebrated the 25th anniversary in 2021, at that time, IRAD already published more than 100 papers, starting with the first one in 2000 by Peter Hagan, which is the paper with the highest citation, number of citation, over 2,000. We thought to include all the observation, but from a different perspective. Means that not we want to report what IRAD showed, but what the cardiovascular scientific community thought about the IRAD over this long experience. So at that moment, we had 97 studies that were assessed, 82 with more than 10 citations, with the median citation per year for each of these papers 7.3. In that moment, the total number of patients that were considered were up to 10,000. And of course, we wrote that is continuing to expand. Today, we just mentioned 15,000. And we were able to divide also the topics that were included in all these publications based on the section subtype, survival, and also management strategy. As you can see, medical, surgical, medical plus endovascular, and so on. So very peculiar specific points. And this is the base and the core of this paper. Means 69 of these 82 papers were cited by 19 society guidelines of society consensus document. What we did, trying to make something more scientific for understanding the IRAD role, was to do a systematic review on identifying international guidelines in the Western countries, means US, Europe, Canada, Germany, Spain, Japan. These were the countries where we were able to come up with some documents or some guidelines. So 18 of these 19 guidelines that were discovered at the time reported IRAD paper with a percentage of 5.2 papers for each guideline. And also the previous AHA, ACC guidelines, European vascular, endovascular, and cited in a relevant way IRAD papers. And also the last guideline by the European Society of Cardiothoracic Surgery and STS, here represented by Joe Bavaria. So also in this case, there are 6 IRAD papers. So we have 19 guidelines on 20 in the last 10 years that reported IRAD experience. And these were the papers classified in the top quartile based on citation per year. The first one is the one about the partial lumen thrombosis, published by Tom Tsai on the New England Journal. That was the only paper that was published on the New England. He showed that partial lumen thrombosis was present in 1/3 of type E dissection, was a predictor of death at 3 years, and mortality was up 30%. And it was interesting to see that to show up how this was possible, he went to a lab and he developed an in vitro study which showed why this patient presented an enlargement of the aortic diameter of the time, because the blood flow was able to move through the endothelium. From the true to the false lumen, it was difficult to move from the false back to the true, increasing the diastolic pressure. The second paper is by Linda Pape and took in consideration the diameter, as the threshold for ascending repair was 5.5 centimeter. But Linda showed that 59% of these patients had already these at the diameter less than 5.5. And we are talking about already dissected aorta that probably presented with an even smaller diameter before the acute event. And 40% of these patients presented with dissected ascending diameter less than 5 centimeters. That was a very important observation. The third paper is about the incidence and treatment of intramural hematoma by Arturo Evangelista. Arturo showed that about 6% of these patients may be affected by this peculiar dissection with the similar characteristic outcomes compared to the classic acute type A dissection. The fourth paper is about young patients with acute dissection by Jim Giannuzzi. 7% of these patients had less than 40 years, and the vast majority of these cohort were Marfan patients, presenting with a similar outcome, but with a bigger aortic dimension from the annulus to the root to the sinotubular junction up to the ascending. The fifth of this paper is the one by Toru Suzuki on the role of the dimer used as testing the importance and the possibility to make a quick diagnosis in acute dissection. We end up with these results, means when we have less than 500 nanograms per milliliters, within 24 hours, we can rule out this patient from having aortic dissection. But if they have higher than 1500 within 6 hours, they might be highly suspicious for acute dissection. In addition to these 5 papers, We have other papers that are considering the higher number of the total citation. Of course, here there is a bias related to the year of publication. So those in bold are the 5 papers that I mentioned, and the others represent the 10th in total out of the first by Hagan in 2000. That is by far the highest cited IRAD paper. So again, Tom size on follow-up for B dissections. 1/4 of these patients deceased at 3 years after the acute event. This is a paper on by our group on results for type A. This section overall mortality in the first time in IRAD was 25.1%, but we were able to characterize 2 groups, unstable and stable, and you can appreciate the difference. I will show a bit more later. Then we have also a paper highly cited by Rajendra Mehta on the models related to observed versus probabilities of death for type A dissection. Another important paper was another by Linda Pape that reported the trend in overall results, specific results after 17 years. As you can see, for type A, much better than for type B. Then we have another paper for surgical results in those affected by B dissection, mortality extremely high, almost up to 30%. Some predictors of surgical mortality were older age and preoperative shock condition, and this was directly related to another important paper, highly cited as well by Rossella Fattori, that posed the question about complicated UB dissection. Is surgery still the best option just because the relevant number of mortality for open repair of these patients? And then we have also key findings. So we have additional observation that, of course, we cannot skip because we are on time, so we can continue. First of all, I would say hyperacute phase is the first observation about the increasing risk for mortality within the first day by Anna Buer. It then was highly cited till was included in all current guidelines, also the last one by ACC managed by Eric Selbacher. And this was probably related to the surgical papers that I was showing you, unstable and stable, and it was interesting to see that the difference in mortality between these 2 groups were present only within 24 hours. After 24 hours, there were no difference in these 2 cohorts. Probably the worst time of their natural history was exactly present within the first day, and then the natural history took its course. What about the age? Even for type A, of course, we can say a reduction in medical management and reduction in surgical management, blue line, reduction in increasing in medical management over the time. However, this patient showed another topic. Over 80 years, surgery was still associated with better results than medical, even in patients older than 80, at least up to 85 years old. Age, of course, matters also for B dissection, and this paper showed that unfortunately age is related to a poorer outcome regardless the type of procedure. Another topic was about diameter for Bs. In this paper, we observed that up to 80% of these patients who presented with descending dissection had a diameter smaller than 5.5 centimeter. And you can see that the median diameter for this cohort was just up to 4 centimeter. This means that probably they have 3.5, 3.8, 3.2 centimeter before their dissection. That's another important key find by Marco Di Ausanio. Related to the stroke in acute type A dissection, patients with cerebrovascular accident and or coma And Marco said that the outcome in these patients is still better after surgery than medical procedure, even if they present with a very catastrophic complication. And similarly, Marco, in the same year, reported about visceral ischemia for type A dissection, incidence low, mortality high, but better results if these patients are treated with an extensive aortic repair that might include also frozen elephant trunks, means treatment of the entire arch and the descending aorta. And this was present also for B dissection, where visceral ischemia impacted the results in an important way and drive us to treat this patient with additional stent within the thorac-abdominal dissected section, aortic section. And then we have the group of papers related to trends. This is the paper that we presented to the Aortic Symposium, which is the most important, by far, aortic surgical meeting in the world, organized by AATS. And this was the result that showed the decreasing mortality over the time in the IRAD up to 12%, which is a fantastic result if we consider the higher number of the centers and the higher number of surgeons who took care about these patients. And this, of course, is mostly related to the fact that for type A dissection managed surgically, many additional things have been introduced in the daily practice, as arch repair, as perfusion, as sparing of the valves, even many things. So these are definitely associated with this point. What about the trend? Linda showed that the overall mortality for type A decreased in an important way from 31% to 21%, 10% in percentage over 17 years. I'm talking type A overall. No similar results were showed for Bs, where mortality remained the same, almost increased over the time. So we need to wait for additional 5 years until we collected other 1,000 patients, when we recently were able to show that the results are also good in terms of trends for B dissection, and we have a decreasing overall mortality regardless of the type of a procedure, medical, surgical, but finally, let me say, also endovascular. And these are also the pretty good result, 3 years follow-up of these patients. What about the arch? That's a controversial anatomic location, very short, 3-4 centimeters. How we can define proximal entry tear in the arch? Not easy. Now we have very good imaging, so that it's much easier than before. We try to figure out this group of patients as arch A, when the proximal entry tear was located in the arch with the retrograde ascending involvement, and arch B, where the entry tear was in the arch, but there was no ascending involvement. We analyzed this group, number of patients was enough to say something. Some CTs reporting specifically on the type cohort, and of course, we noted that there was a similar incidence of preoperative complication, although these complications were completely different, because of course having the ascending involved or not by the dissection change completely the complication and also the game. And interesting to note on the right-hand side of the columns to see that for those of type of arch B, means with the tear in the arch but no ascending involvement, mostly these patients were treated medically. This means that the daily practice was over the guidelines at that time that said that for tear in the arch, open repair was the indication. Another important key finding is by Eric Selbacher about a recurrent dissection, very peculiar topic too. About 20% of these patients may present with this typical complication, mostly are Marfan's, and more frequently B's, and less frequently type A, probably because Marfan had already a surgical repair, so this might be the reason. And another important key find is by the race, Eduardo Bossone was able to stratify results, management, incidents by the race, and this is one of the beautiful things of this registry, means giving us the opportunity to really stratify patients about whom it's so complex, almost impossible, let me say, using different cohort or single center data. Kevin Harris reported recently on JAMA about early type A mortality, much higher for type A treated medically than treated surgically. And he defined it in the medical group, mortality for A's was 0.5% per hour, while this was much decreased for the surgical group. After 2 days, mortality was about 4.4%. And then again, predictors also for B, aging, shock, always, but also presence of other issues like periaortic hematoma, larger diameter, which means aneurysm, and ischemia, acute renal failure, peripheral ischemia, of course. Other relevant key find was the definition of this cohort group, recurrent pain and hypertension. Basically, this is the first paper in the literature that reported about these patients that were classified as affected by a soft complication because there was no ischemia, there was no rupture, there was only pain. But if they were not treated on time, you can see on the right-hand side that the mortality was much higher than those that did not present with this complication. About intramural hematoma, again, patients are older and more frequently present distal aortic involvement. And when we compare the intramural hematoma in type Bs with those affected by classic type B dissection with patent true and false lumen, we observed that there was a higher medical management for intramural hematoma than type B classic dissection. And what about this key find about activity recommendation by Eva Klein, Rogers, and the group, the team? There was an interesting paper, one of the first to give some support to the patient. This is probably the paper that I give more to the patients when they come in outpatient clinic. What I can do? I don't know what you can do, but Eva knows, and the group. So please refer to her in terms of aerobic exercise, even weightlifting, and also a common sense approach to sexual activity. I don't know what you mean, Eva, but this was reported in the paper. And we have ongoing projects, so probably it's already it's a slide that is moving ahead in a very quick way. We have a new paper. So limitation, of course, it's observational registry. We do not have information about all cases, but we have a good perception from the highest cardiovascular scientific community in this world. These are the guidelines that cited the IRAD registry. We have working groups that are going on very nicely and quickly with a lot of interest. But there is also, let me have the chance to give you also what IRAD gave me